Hello and welcome to our listeners around the world. You're listening to the JAMAevidence User's Guide to the Medical Literature podcast. Thanks for joining us. I'm your host, Dr. Gordon Guyatt, Professor of Medicine at McMaster University in Hamilton, Ontario, Canada. And today I'm joined by Dr. Toshi Furukawa, Professor Emeritus at Kyoto University School of Public Health in Japan. Today we are talking about understanding bias and random error in medical research. Toshi, welcome.
Thank you very much, Gordon, for having me.
Well, it's a real pleasure. Toshi and I are old friends from way back, so it's great to be talking with you today, Toshi. So let's start out. Why are bias and random error juxtaposed, contrasted with one another? Are they related? What's the relation between them?
Yes, we are talking about how we can estimate the underlying truth, and then what we get in a study and the underlying truth do not always coincide. And that difference is called error. But error can be divided into two types: random and systematic. Bias is just another name for systematic error. And that's why we have random error and bias juxtaposed.
All right. So if I understand it correctly, two reasons that we may get the wrong answer. We're looking for the right answer and we get the wrong answer. And one is systematic deviation from the truth, like underestimates and overestimates of the effect. And other is just random error. Maybe overestimate, maybe underestimate. Doesn't happen systematically, it's random. So far, so good?
Exactly. And just to have an idea of that two types of error, it is very convenient to think of a study as an attempt of throwing a dot at the dartboard. The center of the dartboard, or the bullseye, that's the underlying truth. And every study is an attempt to reach the bullseye, but you cannot always hit the bullseye. A random error is when your dart is away from the bullseye in all directions randomly. A systematic error is when your dart hits away from the bullseye in a certain direction. That's why it's called a systematic error, which is bias.
Okay, that's a very interesting metaphor for it. So if I am a dart player and I'm throwing it at the bullseye, I'm not going to hit the bullseye every time. And if I'm not such a good dart player, it's going to be off. But if I'm targeted on the bullseye, sometimes it'll be upper right, bottom left, all around it in a random way. But if for some reason I have a tendency to throw toward the upper right-hand corner, there'll still be a random distribution around the upper right-hand corner, but it'll be systematic. So the first one is random and the second one is systematic. And the systematic will always have random associated with it. Have I understood the dartboard right?
Correct.
Okay, great. So far, so good. We often hear the expression risk of bias. Why do we add risk of? What's the difference between risk of bias and bias?
Well, this question has puzzled me for decades after I started learning epidemiology. But now I think the secret is in the previous metaphor, we were talking about the bullseye. That is the underlying truth. But the truth of the real world is we don't know where the bullseye is. We don't know where the underlying truth is. And therefore, we cannot know if it's a bias or not. All we can talk about is how likely or how probable the bias is. And that's why in the real world, we can only talk about risk of bias.
That is, again, nice to bring us back to the notion that we are searching for an unknowable truth. We'll never know for sure what the truth is, and we're hoping to get as close as possible to what that underlying truth is. There's the difference between risk of bias and bias is actually, I find it very important talking to lots of people. And the reason is, for instance, somebody isn't blinded in a trial. We don't know if that's going to bias things or not. Maybe in some situations it isn't going to bias things. And sometimes we can say, in this situation, it's probably not going to bias it or unlikely to. So it's always just a risk. Sometimes the risk may be high, sometimes the risk may be low. And so differentiating, understanding that it's a risk, and sometimes there may be a risk, but it's a very small risk, and sometimes it may be a very big risk. So that risk is really important to know about when we're considering bias. All right. We also often hear about validity. How is validity related to bias? How is related to random error?
Well, systematic error is synonymous with bias, and bias is synonymous with threat to validity. Threat to validity means how likely your study is to be hitting the bullseye or close to the underlying truth. So validity, bias, and systematic error are all tied. Now, there is a place to play for the random error in terms of the validity. When the random error is very wide, the study may be considered less trustworthy, but would you call that study invalid?
So you are raising issues of difficult and challenging terminology. And for many of our audience, they would like to see things made as simple as possible. And I think here that I would be inclined to make it as simple as possible. And you have done that, I think, in the first part of your answer very well. Okay, so a study with high risk of bias will be likely to be invalid. Validity will have to do with our success in reducing bias to the minimal. A valid study will be one in which we've reduced bias to the minimal. For instance, in randomized trials, we'll have concealed randomization and blind everybody and not lose any patients to follow up. And as a result, we will have a study with low risk of bias, which will give a valid result. So I would put it that way and say, as you've done very nicely, validity is synonymous with bias. A valid study will have low risk of bias. An invalid study will have high risk of bias. So the two are related in that way. Does that make sense?
It makes perfect sense to me, yes.
Okay, good. Well, hopefully it'll make good sense to our listeners as well. Okay, now we've got the idea. Bias or lack of validity is systematic deviation from the truth. How can we know about the risk of bias? We'll never know if it was biased or not, but what we can identify is the risk of bias. So how do we identify risk of bias?
That's the most important message of this podcast, in the sense that the risk of bias of a study is dependent on the methodology of the study. And depending on what the bullseye or the underlying truth that each study is trying to arrive at, the weaknesses of the methodology of the study will be different. So, for example, a study that is trying to estimate the treatment effect will be affected by the factors that you just listed. But studies that aim at assessing the diagnostic accuracy will have other sources of bias, and studies that aim at prognosticating certain people will have different sources of bias. But in general, they are all related to the methodology of such studies, and the previous studies for the past 2 decades, I guess, have all elucidated what types of sources of bias are important in each type of the studies that I just listed.
That is a great, super, and crucial point that risk of bias differs depending on the study design and the target, what we're trying to get at. So, if I understand it, if we are talking about therapy, we want to know if a treatment works and how much it works. Ideally, we're going to have a randomized trial. And the issues of randomized trial and risk of bias are concealment of randomization and blinding and loss to follow-up. There are others, but those are the key ones. But sometimes we don't have randomized trials. Sometimes we have non-randomized trials or observational studies like cohort and case control studies. And concealment of randomization is irrelevant because there's no randomization. And in these observational studies, you can't blind anybody, so that's not important. But minimizing loss to follow-up is, and getting representative populations is crucial. And as you pointed out, for diagnostic tests, the risk of bias issues are really quite different. They have to do, for instance, with the people looking at the test and the people looking at the gold standards to which the test is being compared are blind to one another in terms of the person doing the looking at the test doesn't know the gold standard. The person doing the gold standard doesn't know what the test result showed. So, as you very nicely point out, different targets. Is the target getting a treatment effect, or is the target getting a diagnostic test? Finding out whether a diagnostic test is a good test or not. With different targets, we're going to have different issues of risk of bias. And even with the same target, finding the treatment effect, we have different risk of bias issues in randomized trials and observational studies. So you've hit on absolutely a key issue in finding out whether there's bias. You have to know your target and you have to know your study design.
Exactly.
Good. Okay, got that right. What about random error? How can we know if there's random error?
So we have been talking as if random error is less of a problem or a smaller problem than the systematic error. Why? Because random error can be more visibly quantified and assessed. Typically, the random error can be estimated by how wide the 95% confidence interval is. And the random error is typically determined by the sample size and also by the unreliability of the outcome measurement. But in both cases, as far as I understand, the degree of random error can be quantified or summarized by the width of the 95% confidence interval.
So that's a great distinction, which I love, because if, say, a study is unblinded and we say, how much was the risk of bias as a result of the unblinding? It's very difficult to put a number on it. In fact, it's so difficult, we tend not to do it. We just say, well, it seems like the risk of bias is pretty high there because of lack of binding. Or if the outcome is all-cause mortality, then maybe the lack of blinding isn't such a big deal and not much of an issue. Well, very vague language. But when we're talking about random error, we have a confidence interval. Our point estimate is a 50% relative risk reduction, and the confidence interval is from 40 to 60%. Oh, not much random error. Or our point estimate is a 50% relative risk reduction, but the confidence interval is 10% relative risk reduction to 90% relative risk reduction. Lots more random error. On the first one, much more of a guess, and we're using, as a result, we use qualitative language. With the random error, we have our confidence interval, and it gives us numbers. So it's much easier to quantitate than is the risk of bias, which is a great point that I'm glad you pointed out. So we're doing pretty well here, I think. I have the impression anyway, in terms of characterizing risk of bias when it occurs and how we measure it, and random error. when it occurs, which is always to some extent, and how we quantitate that. Toshi, is there anything else you would like to tell us before we sign off about bias and random error?
I think this illustration of the dartboard is very telling. And with this in mind and with our explanations, I hope the listeners can now have a much clearer understanding of the bias and random error. And I have been teaching in the School of Public Health for the past decade and a half. And what I noted is that when new students come in and start to learn epidemiology, they always start talking about bias and confounding. And they tend to say, this study is biased. But they have very vague idea of what bias means. I hope this podcast will illustrate the bias is a very technical term, and when you say that a study is biased or is at high risk of bias, I do hope that you have this explicit definition of bias in mind.
Okay, thank you. Very interesting to hear you talk about your many years of experience teaching in the School of Public Health. So thank you very much, Toshi, for joining us.
Thank you very much.
I'm Gordon Guyatt, and I've been speaking with Toshi Furukawa about bias and random error in medical research. You can find a link to this chapter in this episode's show notes. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.